And I guess I need to speak to this, into this, right? Okay, good. I'm going to put a timer for myself so I will not be scolded later. Um, it's good to be here. Thank you to the organizers for inviting me. And I guess a mistake of the organizers was to let people go out for lunch. It's just so beautiful. People didn't want to come back. But I guess most people are back now. Last night as we were having dinner, I was thinking about how long I've been doing Lyme disease research. It actually goes back to 2002 when I was a postdoc, so it's been a really long time. And my focus really has been on the chronic manifestations of Lyme disease. That's been my focus when it comes to Lyme disease. But I'm really interested in conditions that are basically spectrum conditions where they're heterogeneous, the patient population is stigmatized, somewhat ignored by the medical community. They're very difficult to study, we don't have biomarkers for, and there is very little funding for it. Of course, I didn't realize that last one until I really got into it, so I wouldn't have done it until. So I thought I would talk about some of my own work and really review this post-treatment Lyme disease syndrome condition that John talked about a little bit in the morning. And when I say mechanisms and biomarkers, I'm really referring to inflammatory mechanisms and biomarkers. And I hope that by the end of this talk, I will have convinced you that most patients have a persistent inflammation, and that it's really a dysfunction of the immune system that is contributing to symptoms, or at least associated with the condition. So where is the slide changer? Is it this? Oh, I'm sorry. Is it this one? Yeah. Okay. And sorry, which one is for? There we go. Okay. I've never seen one like this. It's cool. Okay, very good. So I'm going to cover these topics. I'm going to talk about, what are the chronic manifestations of Lyme disease? What are the mechanisms of the post-treatment symptoms? And when I say post-treatment, I mean that patients who have been treated with antibiotics but continue to have persistent symptoms. And what is the available evidence? I'm going to focus only on what's published and what there is some kind of agreement on in the literature. And what are the unmet needs regarding research on post-treatment manifestations of Lyme disease? And finally, talk a little bit about recent progress and what I think can be and should be done going forward. So you got a beautiful introduction to Lyme disease this morning. I'm not going to go into it deeply, but just to say that Lyme disease is caused by the Borrelia burgdorferi species complex. In the US, the primary species that causes Lyme disease is Borrelia burgdorferi. In Europe, we have other ones as well. The estimate of individuals diagnosed each year is about 300,000. It's probably an understatement. Probably there's a lot more than that. And this is an estimate based on certain sort of assumptions. But think of Lyme disease as a condition that has multiple stages. And remember all these stages, and these were also, they're the same ones that John presented this morning. So the very early stage of Lyme disease is right after the tick bite, and we call that early localized when you have the skin lesion. And Olivia gave me a card, and others a card last night to remind us that not all people get the skin lesion, which is really important to remember, which of course complicates the diagnosis of Lyme disease. The organism then moves away from the skin into the blood, and we call that early disseminated, can get into the nervous system and the heart as well. And that's days to weeks after the initial exposure. And then we have late Lyme disease, where it can be months to even years after the original tick bite. And the primary manifestations are neurologic and arthritic. So that's the different stages of acute Lyme disease. But about 10% of patients who have Lyme arthritis don't respond to the antibiotic treatment, and go on to have persistent joint inflammation. And now this is objective joint inflammation, clinically obvious. These patients usually respond well to anti-inflammatory agents. So we know that this condition is inflammatory. I'm not going to talk much about antibiotic refractory Lyme arthritis, other than just to say that there is clear evidence that it is immune-mediated and inflammatory. And then there is the condition we call post-treatment Lyme disease syndrome, or PTLDS, or it's also referred to as chronic Lyme. Patients experience fatigue, pain, difficulties with concentration and memory after standard antibiotic treatment. Okay? It's not the same as antibiotic refractory Lyme arthritis. It's very different. And prevalence is it's not very clear, but about 5 to 20%, that's the estimate, which is not trivial. If you think about at least 300,000 patients being diagnosed with Lyme disease, you can imagine the numbers that we're talking about when it comes to these chronic manifestations of Lyme disease. So what is the definition? So, when we recruit patients, when we're doing science, we need to have clear definition. So since you don't have biomarkers, we need to have definition to recruit patients. The symptoms that we always think about when we think about PTLDS are fatigue, pain, and cognitive difficulties. And it's basically the onset and persistence of these symptoms have to be between 6 and 12 months after the diagnosis, and they have to last longer than 6 months. That's how we define a post-treatment Lyme disease syndrome for the purpose of recruitment into these studies. So the studies that I will show you all follow this definition. Not a lot of research has been done in the context of the health impact of Lyme disease, but there are a couple of studies that I want to mention here. There was this first study. This was actually a clinical trial that some of you may be familiar with, that was published in New England Journal of Medicine. The study didn't show an effect of antibiotics, which most people have focused on, but I think this was a really important study because it showed the huge health impact of post-treatment Lyme disease syndrome on the patients. It showed that what they are experiencing is equivalent to congestive heart failure. It's greater than type 2 diabetes or a heart attack. And whenever I apply for funding for at NIH, I always mention this because this is really important to understand why we need to do more research on PTLDS. And a more recent study showed that the vast majority of the disease burden associated with Lyme disease as a whole, and there I'm talking about acute and the persistent post-treatment manifestations, most of the disease burden is actually associated with the post-treatment symptoms, not with the acute manifestations. Again, really important, showing the importance or the significance of more funding that's needed for research on PTLDS. There is also a significant economic impact, as many of you would know. There hasn't been much work on this, but there was a really great study, a very important study that came out a few years ago. It was a US study showing that there is a substantive economic impact to PTLDS. And it is also associated with a greater outpatient evaluation and management visit by the patients. Now, that's the direct health impact, but we know that there has got to be an indirect economic impact as well associated with loss of household and labor force productivity. That has not been researched yet. So this is the problem that we have with this condition that we call PTLDS. Still, we don't have a clear evidence for causality between Borrelia burgdorferi and PTLDS. And our understanding of the mechanism is also fairly primitive. I'll show you a lot of data that shows how things have changed since the time that I started doing research on this, when people did not believe that this condition existed, as John alluded to it. Things have really changed. I think now you have many articles, papers published on this. I think now we accept that this is a real condition with objective markers associated with it. The other problem is that we don't have an animal model available for PTLDS. People have done studies on animals showing persistence of things, but not associated with symptoms. We don't have that yet, and that's really important to reproduce PTLDS. And we also don't have established biomarkers. Biomarkers are important for diagnosing patients, understanding the risk of developing PTLDS, and also recruiting patients using objective markers to study the condition. So really important. So let's talk about the pathogenesis. What do we know? What are the main hypotheses out there? And this was mentioned earlier in the morning. Persistent infection is one of them. And I'm going to talk about each of these in the next few slides. So persistent infection, and then the second one would be immune-mediated mechanisms. And I put this as one thing. Immune-mediated, it could be the original infection that's triggering immune responses, inflammation, or it could be remaining spirochetal debris, and there is some animal data in that direction, which I will show. And then, of course, it could be other causes, right? It could be other infections, et cetera, which I will not go into. So I'm going to focus on the first two. Those two. Okay. But what I want you to remember and always think about, and what is sometimes missing from some of the presentations that you see or some of the conversations, is that this is a spectrum condition. This is heterogeneous. And not all patients are alike. And what we want to do is basically break down this condition into subsets to understand it better, to find biomarkers for the various subsets, and to be able to identify treatments for those subsets. Because if you take the whole population and you apply one treatment, it's not going to show efficacy because it is heterogeneous. There's different stuff going on in the PTLDS population. So the data that I will show you indicates that there is something going on in a lot of patients, but still it's not every single patient. So here we have a spectrum condition. Okay, so what's the data for in support of persistent infection? Let's look at the animal data first. There are several studies indicating that you can have persistence of non-cultivable B. burgdorferi after antibiotic treatment. And this is data that comes from immunohistochemistry, looking at the actual organism in tissue, DNA and RNA transcription, xenodiagnosis, which is basically putting a tick on an animal and then looking at the tick for the presence of the bacteria. And then looking at also the immune response to tissue that may contain Borrelia. So there is all this data out there indicating that, yes, you can get Borrelia burgdorferi particles, debris, or even intact but not cultivable and not infectious in animals. And let me show you a few papers on this. So this is actually a really nice paper. It was one of the first papers that was very elegantly showed that Borrelia burgdorferi antigens or particles can persist after antibiotic therapy in mice. Okay, in mice, and here you can see in the left panel you can actually see the antigens of the Borrelia, and in the right panel they actually took some of those tissues and found that those tissues containing the Borrelia antigens were able to trigger immune responses. This was a very important study. Another study, very similar in some ways, again in mice, showed that they found actual Borrelia intact-looking Borrelia in tissue of animals treated with antibiotics. And they looked at various tissues. In the left panel, you can see that 12 months after antibiotic treatment. But these bacteria were not cultivable. Okay, so that's the mice. And so let's look at something closer to humans, the macaque model, which is the most representative animal model of Lyme disease, acute Lyme disease. And they found very similar things. The persistence of the Borrelia sometime after antibiotic treatment. And they found that by xenodiagnosis, there was Borrelia, but it was not infectious. It could not infect mice. Okay, so all of this data so far shows that you can actually find borrelial antigens or immunogenic borrelial particles or debris, but these are not infectious. That's where we are with the data. What about the human data? Where are we with this? I would say the evidence for persistence of infection, acute infection in humans after antibiotic treatment is still weak. There may be case studies out there, but large studies have not been able to show that yet. We may get that in the future. There was an important study a few years ago where they basically were looking at the presence of borrelial or spirochetal debris in humans or in patients that had PTLDS by xenodiagnosis. So again, they put a tick on humans, and so they had volunteers who were willing to have a tick feed on them. And then, I guess you're not going to volunteer, whoever laughed. And then looking for evidence of the Borrelia in the tick, okay? And they found it in 1 of the 10 PTLDS patients. That's very interesting, but this needs to be replicated, but and it is only 1 out of 10. You know, we can. It's very provocative data, but we need more than that to make any sort of conclusions about persistence of infection in humans. Okay, so that's the persistence of actual infection or spirochetal debris. Now let's look at the second sort of hypothesis that I mentioned earlier, the immune response, the presence of an immune-mediated condition in PTLDS patients. So there is, of course, a very robust immune response associated with Lyme disease, as we all know, and which is, of course, a source of biomarkers and a lot of insight into the mechanism of the condition. And when I started out doing research, I thought to myself that if this condition is immune-mediated, at least in a subset of patients, we must be able to find differences in the immune response of patients, that is, people who don't recover fully, and those who recover fully, because there are a lot of people who recover fully from Lyme disease, right? We must be able to find, so if we keep comparing in well-controlled studies, people who have had Lyme disease and don't recover to those who do recover, we might be able to find something. And not just comparing to healthy people, but people who have had Lyme disease and have recovered. So I'll show you some stuff, basically looking at the IgG and IgM antibodies to specific borrelial antigens, autoantibodies, cytokines, and I'll finish up by some sort of other potential markers that may be useful here. So the immune reaction, of course, to Borrelia burgdorferi is very robust. There's a very robust antibody response to the organism's proteins and glycolipids. This is, of course, as you know, used extensively in serologic assays to aid diagnosis. You all know about the so-called two-tiered algorithm that's been recommended since 1995. And basically the way it is that the blood gets tested for the presence of an antibody response to Borrelia, first by what's called an ELISA. It's a plate where you put the blood in and look at the presence of antibodies to borrelial antigens, the whole cell mix of borrelial antigens. And then if it's positive, people do Western blot. And in Western blot, the borrelial particles are separated, and then you look at the certain number of bands, and if they're positive, you say it's positive. Okay, so of course, there is a problem with this test, as you know. So here's the stereotypical antibody response to any infection, right? And in Lyme disease, it's the same thing. And I've basically shown you from the left, from healthy to single erythema migrans lesion, to multiple lesions, to early neurologic, to late neurologic, to arthritis, and finally with PTLDS. And so this is what it looks like. The antibody response goes up and stays up for practical purposes. It stays up. It can stay up for years. So we have a problem. If you look at this, you can see that there is a problem early on, right? We don't have sensitivity in the early part of Lyme disease. And that's an important part of or stage of Lyme disease, because if you don't treat in that early stage, there is some evidence indicating that patients are more likely to have post-treatment or chronic symptoms. We also cannot tell the difference between PTLDS patients and people who are healthy. They both have a high antibody response, usually, and we can't differentiate. So the two-tier test is not useful. It's only useful in the two extremes. It's only useful in the middle part. And I'll show you here some data here, actually. You can see that I'm separating them into IgG and IgM. You can see that post-Lyme disease syndrome and post-Lyme disease healthy, there is no difference in the antibody response between them. So the serologic assays that are available commercially are of no use for differentiating those patients. Now, there's a new generation of antibody tests for Lyme disease that don't look at the whole cell lysate of Borrelia, but actually look at specific antigens or specific parts of those antigens. By the way, I just want to mention this. You probably have heard of this, a lot of you, that FDA just cleared basically the possibility to make changes to the two-tier test using these new assays. So you don't have to do the two-tier test in that rigid format. So this is an important progress, I think. As I said, the immune response to Borrelia targets a lot of antigens. And I want to focus on this guy over here. Can you click on that and make it turn, if that's possible? This is just one of the proteins of Borrelia burgdorferi. It's a very cool-looking protein. I just took the data from the crystal structure and plugged it in and made this molecular model. But this is the protein which patients make a lot of antibodies to. And the yellow part in the middle is the part that was found to be the main part of the protein that patients make antibodies to. That was discovered in '99, and the blue part was discovered in 2011 by my lab. Patients make a lot of antibodies to these three sites. If you look at the antibody response, and by the way, the C6 assay that a lot of you are familiar with looks at antibodies to that yellow part in the middle. Okay, so a specific part of the Borrelia VLS. This is called VLSC protein. You can see that the antibody response in PTLDS patients and post-Lyme healthy individuals does not differ. It's the same. For the C6 epitope. There is no significant difference. But if you look at antibodies to the membrane proximal region, that is the other two that are in the bottom, you can find a significant difference in patients who have post-treatment manifestations and those who don't have post-treatment manifestations. And in fact, there's a very different response to the antigen or to the epitope across the different stages of Lyme disease. As you can see, antibodies to C6, to the yellow part, go up very early. But antibodies to the other two parts are almost non-existent in the early stage of Lyme disease and only go up in the later, more chronic manifestations of Lyme disease, Lyme arthritis and neurologic Lyme, and are elevated also in PTLDS. Again, this was one of the first indications for us that there is a difference in the immune response to borrelial epitopes. I don't have time to go into the reason for that, but I'll be happy to discuss that later. We also have evidence that patients, the PTLDS patients, have higher levels of autoantibodies. We've looked at antibodies to neural antigens and find the levels of these antibodies to be similar to what we find in lupus patients. That doesn't mean that these antibodies are pathogenic. I'm not saying that. But we do find high levels of these antibodies which point to persistence of inflammation. We also do find these antibodies in acute Lyme, especially in neurologic, late neurologic, and Lyme arthritis. This points to the fact that there is persistent inflammation in these patients. And whether seropositive or seronegative, they have these antibodies. This was another study that, again, replicated that. You can see that patients have, on the left panel, PTLDS patients have antibodies to dorsal root ganglion neurons, and the post-Lyme healthy individuals do not have those antibodies. And this antibody response did not change in response to antibiotic treatment. There is also data, we've shown that there is an elevation in levels of interferon alpha in patients specifically associated with objective cognitive deficits in these patients. And there is actually a lot of data out there. A lot of clinicians know that interferon alpha administration is associated with cognitive deficits. So this was very interesting because it showed a specific objective cognitive deficit being associated with levels of interferon alpha in these patients. A more recent study has shown that PTLDS patients or patients with Lyme disease who have higher levels of IL-23 cytokine are more likely to go on to develop post-treatment Lyme disease syndrome. And IL-23 is basically a cytokine that is associated with the Th17 immune response and actually inhibits the regulatory T cells, and it's associated with a sort of a lack of regulation of inflammation. So again, pointing in the same direction. And this is another nice study that showed elevated levels of CCL19. It's a small study, but it showed that it followed patients and showed that in these patients, the patients with higher levels of CCL19 chemokine, those were more likely to develop post-treatment Lyme disease symptoms. Again, indicating a persistence of inflammation in these patients. Okay. Quickly, I just want to mention the acute phase immune response. I've been talking about the adaptive immune response in Lyme disease and in PTLDS, but I haven't talked about the acute phase immune response. Every infection is associated with an innate immune response. So we make proteins that are not specific for the Borrelia, but are specific for many infections. And their levels go up very, very quickly within the matter of sometimes hours. And two of those proteins are, a lot of you have heard of, CRP or C-reactive protein and serum amyloid A. These are the prototype acute phase proteins, highly sensitive. I'm going to just show you a little bit of data on CRP, which is associated with both infection and inflammation. And what's special about CRP is that it basically goes up very quickly, very rapidly, and then as soon as the infection or inflammation is resolved, it goes down very quickly. So it can be very useful, unlike the adaptive immune response, unlike the antibodies, it can be very useful in following infection and inflammation. And here's actually some data showing that the levels of CRP go up very quickly, even faster than the antibody response, but then go down during the later stages of acute Lyme disease. But what's really interesting is that the levels go up again in the chronic post-treatment manifestations of Lyme disease, including antibiotic refractory Lyme arthritis and in PTLDS patients. And there's a very significant difference. Now, I'm not talking about p less than 0.05. This was a huge difference that was observed in these patients, and that there is a correlation between the anti-neural autoantibody response and this CRP response, again, pointing to inflammation here. I'm not talking about these molecules necessarily being pathogenic in any way. And we've also compared this to patients with chronic fatigue syndrome. My lab does a lot of work on chronic fatigue syndrome as well. And unlike the chronic fatigue syndrome cohort, which is even more heterogeneous than PTLDS, we did not find this elevation in CRP. However, what was interesting is that the two patients with the highest level of CRP among the chronic fatigue syndrome patients actually were the only two that had a history of Lyme disease. It's just an interesting observation. So to finalize, you can see here, this is the antibody response that I showed you. The green is the antibodies to the C6, the red is the antibody to the whole cell Borrelia. It basically rises slowly. That was mine. And then it stays up. The antibody to the other VLSC epitope doesn't go up until much later, and it actually is elevated in PTLDS patients and not in post-Lyme healthy individuals. And then the CRP story is also very interesting. It goes up very quickly, more quickly than any antibody response, so it could be useful in the very early stages of Lyme disease to inform the diagnosis of Lyme disease possibly. It's not specific to Lyme disease, but it's also elevated in post-Lyme syndrome. I just want to mention that we can use these markers. The hope is to have a sort of a diagnostic algorithm, not just one marker, but a combination. And we've used these combination of markers to differentiate between post-Lyme syndrome and post-Lyme healthy individuals. There is a lot of new research on different biomarkers. I just want to mention one of them that I found interesting, looking at the metabolomic signature on Lyme disease. It's not immune, but of course immune differences can trigger differences in the metabolite signature. This is an interesting study. There have been a couple of papers. It's not shown in PTLDS itself, but I think it has some potential because we're looking at small molecules, and I think it will be interesting to look at these patients. Of course, the ease of use and reproducibility is an issue with any kind of metabolomic study. Okay, so let me summarize and make some conclusions here. So there is now clear evidence for objective differences in the immune response in post-Lyme syndrome patients and healthy individuals, post-Lyme healthy individuals, as indicated by differences in the antibody response to specific Borrelia antigens, the acute phase inflammatory response, cytokines, and autoantibodies. I would say the data now clearly show that there is a persistence or a lack of resolution of inflammation. You can think of it like this, that if you have acute Lyme disease looking like a big fire, that post-Lyme healthy individuals, you just see ashes there. The fire is completely put out, but in PTLDS, you still have smoldering fire or ashes. Okay, so there you have a persistence ongoing of inflammation. The body's immune system has not been able to completely put out the fire. And finally, a combination of markers may be successful as part of having a sort of an effective diagnostic and prognostic algorithm. I think we are getting there. I think in terms of, as we think about the future, where do we want to go? And in my mind, there is a need for greater focus on, first of all, establishing biomarkers in patients to identify patients. It could be one marker, or I think it's going to be a combination of biomarkers for diagnosing, for identifying patients at risk, and also to following a response to treatment. And then the other thing is that we still don't have a good animal model for PTLDS. This is important to identify causality, to confirm causality, and to understand mechanism, and to come up with better therapies for PTLDS. Just want to mention my sources of funding, NIH and Global Lyme Alliance. I'm grateful to them and all the wonderful collaborations I've had. I don't have any relevant disclosures other than I am not related to Armin Labs. Someone asked me, but I am from Ohio, Columbus, Ohio. I usually don't disclose that, but I will do it now. Okay, thanks very much.